It feels like such an honor to be coming back. Thanks for inviting me. That was quite a meeting. I feel like we've known each other a lot longer than the 80s. It seems like we've been lifelong friends and colleagues. And one of the things I don't like doing is following Ted in a talk, because I always want him to keep going. I want to hear more. So he was setting me up, but thanks anyway. So I'm going to talk about suicide loss and complicated grief, and as Ted mentioned, talk about the results of a study that was just very recently completed, and that hopefully you'll find of interest in use. And just starting, I have no disclosures, but I do have a lot of colleagues to thank who I've worked with along the way. Rich Duvall, who I worked with when I was in Texas, and we've had a even longer association than Ted and I. My friend Steve Schuchter, and more recently Kathy Shear, Ron Pice, Naomi Simon, Chip Reynolds, and Barry Lebowitz, all of whom were collaborators in the study I'll be talking to you about. First, I want to just talk a little bit, and I know this is a very sophisticated audience, so I'm not going to belabor a review of ordinary grief, but hitting some highlights that are relevant to what I'll be talking about in complicated grief. Bereavement is often used interchangeably with grief. I'm using bereavement to talk about the fact of somebody dying, losing somebody to death. It triggers a grief response. Grief is a universal experience, something all of us have experienced, many of us many times. We all know what it is, yet it can be devastatingly distressing. It can leave us feeling alone and confused and not knowing what to do, as much as any other life event that we ever do experience. Kathy Shear, I think, is the first to think of grief as the form love takes when someone who we love dies. And I think that's so useful, and that's really a cornerstone of the therapy many of us do, to think of it in that term. That grief is a form of love. It is a price we pay for loving. It's a price that's well worth the cost for most of us, but it is a price. Acute grief is, and we think of the acute grief as the experience we feel in the immediate aftermath of the death of a loved one, and we think of acute grief as somewhat time-limited with many characteristics. One is disbelief. Oh no, this couldn't have happened. Did it really happen? The disbelief Ted talked about with the laundryman, with his daughters, with himself. It's adaptive to some extent. It gives us time to reflect, time to accept the reality of the loss. Sometimes time to do the things that are necessary to do, like dealing with the funeral and dealing with finances, etc. There is certainly a yearning, sorrow, and a host of intense emotions: anger, guilt, blame, loneliness, you name them, they're all there. There are insistent preoccupying thoughts about the person who's died. And in the first days to weeks to perhaps months, those preoccupations are with us very frequently. And over time, they become more triggered and aren't necessarily there all day, every day. There's a sense of insecurity. We've lost somebody who's very meaningful to us in a way that helps us recognize that we also have a certain transience in our own lives. Sometimes we lose a person who has been our caretaker. Sometimes we lose a person we're providing care for. Sometimes we lose a best friend, a lover, etc. So a kind of a sense of the world isn't the same as it was before, and the world isn't as secure a place as it was before, because death is a reality. And for a period of time, a disengagement from ongoing life, where there's a social sanction, bereavement time to take care of things, to be with your family, to be with your friends, and whether that's days or weeks or longer in some situations. So those are some of the key characteristics of acute grief, which I mentioned is time limited, but please don't ask me how long, because it varies. It varies considerably. Some of the characteristics, and these came from a study that Steve Schuchter and I did around the time that we met Ted, that probably in the 80s, looking at widows in San Diego. And some of the generalities from that study is it's clear that grief isn't just an emotion. We often think of grief as the pain, the hurt, the yearning, but it's more than that. It's the way we think, we feel, we behave, we act, etc. It affects all of our being and our functioning. We did learn, one of the things we tried to do is to confirm the kind of Kubler-Ross stages of grief, and we just couldn't do it. It didn't exist that people went through various phases, and within the same day you could have shock and denial and anger, and they go back and forth, and they go back and forth over time as well. So there were no circumscribed stages that we were able to define or confirm. That one of the characteristics of the acute grief response is that it occurs in bursts and waves. It's not persistent. It's not there all the time. In the early days, these bursts and waves are very spontaneous and pretty frequent and often very intense. Over time, they become less intense, less frequent, and more triggered by thoughts and memories and activities related to the death of a loved one. But they never totally go away. I mean, I saw Ted tearing up a little bit when you were talking about Julie. They stay with us, and they stay with us throughout life at anniversary times, at special occasions, etc. But certainly one of the characteristics of acute grief is these bursts and waves do decrease in intensity and frequency over time. One of the characteristics of grief is that positive feelings are intermixed, whether it's humor, good feelings, warmth in talking about the person who died, warmth in being with family members and other folks who share memories and retell together. And sometimes people feel guilty about having these positive feelings, and as a therapist, it's very useful to normalize those kinds of feelings, that it is part of the normal grief response to feel positive, to feel humor, to be able to laugh, to be able to enjoy memories. And another characteristic is the intensity of these waves and the dysphoria tends to peak in days to weeks to months. If you lose a child to homicide, you would not expect these to peak and go away within weeks or months or who knows how long. On the other hand, when I lost my parents, I was able to get back to work pretty quickly with both of them. I grieved. I loved them very much. I felt sad, but the intensity was not out of the ordinary and didn't prevent me from being with my family and taking care of things within days of their deaths. So that varies a lot, but it does tend to peak, but it doesn't go away entirely. So acute grief can be intense, it can be disabling, distressing, it does tend to decrease in intensity, but it doesn't permanently go away. Rather, the mourning process helps us transform acute grief into what we call integrated grief, which is a permanent state. In integrated grief, the yearning, the sorrow is still there, but it's muted. Thoughts are accessible. They may be very bittersweet, but they're not there all the time. They're not preoccupying. They're not as distressing. They're often very positive memories, even if they bring tears to our eyes. Every time I see, I just saw my middle granddaughter in Los Angeles last week, who's in the choir, and she was singing for the Jewish holidays. And I couldn't help but to think, boy, my mother would have loved to hear her. And she has my mother's voice. And so the thoughts of my mom were very accessible. And a tinge of sadness along with the pride in my granddaughter, who's so much like my mother. And part of the integrated grief process is their renewed engagement in ongoing life. So acute grief transforms into integrated grief. It doesn't simply go away. It does stay with us. And in adapting to the loss, there are at least three major components, and probably more. One component of adapting to the loss of a loved one is coming to grips with the reality of the loss, both emotionally and cognitively, and understanding for yourself what it means to you that your loved one is really gone. So part of it is accepting the loss, but at the same time, another part of it, equally important, if not more so, is now accepting what your new relationship with that person is, what that relationship will be like in the future. And Ted talks so eloquently about that in terms of Julie being part of him, the living memory of her throughout the rest of his life. And that heart object there, my heart is perfect because you are inside, came from a young girl who had lost her mother at a camp. I'm going to say a little bit about that in a few minutes. And so accepting the loss and what it means, accepting now the new ongoing relationship, the new attachment, the new living memory with the person who's lost and what that means. And the other component of adapting is getting on with now who you are without the loved one in your daily life in the same way, and your own aspirations, your own goals, sometimes increased wisdom, sometimes increased abilities that one has in the aftermath of losing a loved one to death. But an important part of adapting is coming to grips with who you are and where you're going with your own life. So in summary, bereavement triggers an acute grief response, which over time transitions into integrated grief. Grief is often very painful, not always, often. There's a huge spectrum of how painful the grief experience is. But it is a normal, instinctive response. It requires no treatment. Sometimes support can be useful and helpful. But formal treatment is really not part of what is expected for somebody going through bereavement and a normal grief response. But that brings us to what we call complicated grief. When ordinary grief is derailed, when things don't go well, when adaptation doesn't occur in a healthy, adaptive way. Okay. What do we mean by complicated grief? There are lots of different definitions. The DSM-5 has its definition of, persistent complex bereavement disorder. But the characteristics of it is that adaptation is blocked. Healing just isn't occurring. The healing process of mourning isn't working. Instead of healing, there is a persistent and pervasive yearning, longing, and sorrow. It just isn't going away. A continued preoccupation with the person who has died, difficulty imagining a future with purpose and meaning in the absence of the person who's died, and painful emotional reactions. And some of the comments people make who have complicated grief is all that I have left. If I give up my grief, then that person really will be dead. I can't do it. Okay. Or without the grief, the deceased will be lost forever. It's wrong to stop feeling sad. That would be disloyal. That would be bad. How could I do that to the person who was so wonderful and so meaningful to me? Or a lessening of a sadness is a betrayal of the deceased. Time is moving on, but I am not. And that's a direct quote from someone who was just finished our study. Why do some people have complicated grief and others adapt? Ted raised the question of most people do fine, and we have resilience and adaptive responses, but not everyone does. Some of the pre-loss risk factors that may increase vulnerability are prior psychiatric conditions, particularly mood, anxiety disorders, or substance use disorders. In our study, we found a lot of the people coming to us with complicated grief had previous depression. That's a major, major risk factor for complicated grief. A trauma history, particularly early trauma, early life adversity is a vulnerability factor for a whole host of things including complicated grief. Prior important losses, people can only take so much, and maybe the allostatic load of this yet one more important loss may be too much. Women are more likely to have complicated grief than men. Women are more vulnerable to a whole host of internalizing disorders, and this is yet another. Insecure early attachments, again, are a vulnerability factor, and an especially close relationship with the deceased. That, Freud talked about depression occurring in an ambivalent, with the loss of an ambivalently loved object. And we went in our study and tried to prove that the more people got depressed or had trouble with grief if their relationship was ambivalent, and we couldn't find that. What we did found in very, very strong, loving relationships where people were soulmates, people were mutually dependent, especially in the context of insecure early attachments. So somebody who had trouble with secure attachments finally found their soulmate. When that person dies, that's a real setup for difficulties adapting to the loss. There's some peri-loss risk factors. Ambiguous loss or lack of information, like in the military, or one of the people in our study just suddenly her spouse disappeared, never heard from him again, and assumed because he had been depressed that he went off and killed himself somewhere, but that's a setup again. Unable to follow usual cultural healing rituals, again in the military when somebody dies, that can be a huge impediment to being able to grieve and mourn in an adaptive way. A lot of people try to assuage the intense pain by drinking or substances. That's a setup for complicated grief. That's not a very adaptive response for most people. Absent or hostile social companionship, which we often see after suicide because of all the stigma, again, is a risk factor. And there are also some loss-related risk factors, like, and Ted mentioned again, the prominence of the caretaking role. If you're losing a child who is dependent on you for their survival and security, that child dies, you can have overwhelming feeling that you've let them down, that was your job, you failed. And also just missing the caretaking role in somebody who's been chronically ill can be a risk factor for complicated grief. Especially close relationships, as we've mentioned, and untimely deaths, such as a sudden death, loss to suicide, homicide or accident, or death of a child. And the one that I'll be talking about in the rest of my time is the risk factor of loss due to suicide. A little bit homicide and accident and some comparative things in that. So kind of in summary, a model of complicated grief: bereavement, the death of a loved one, triggers an acute grief response, which activates a mourning process, and for most people leads to integrated grief. Not the absence of grief, not the resolution, not recovery, but integrated grief. We live with it. However, in some situations where there are complications, those vulnerability factors, plus an overabundance of the woulda, coulda, ifs, if only I had done this, if only I took him to the doctor, if only I made him stop smoking, if only I didn't let her have the keys to the car when she was 16, all of those can get in the way and interfere, those kinds of cognitions. Trying to protect oneself from the painful reality by avoidance, by not allowing oneself to grieve, by not even going to the funeral or memorial services, by drinking or drowning your sorrows with substances, etc. And ineffective management of emotions. Those are some of the complications that can interfere with the grief process and prevent grief from becoming integrated and instead lead to what we call complicated grief, where those complicating cognitive, emotional, and behavioral symptoms persist, along with a persistence of the acute grief symptoms: intense yearning, longing, and sorrow, frequent and insistent thoughts and memories of the deceased that are preoccupying, that don't go away, that interfere with our ability to get on with our lives, and difficulty accepting the painful reality or imagining a future with purpose and meaning without the person. So that's what we mean by complicated grief. And it's a disruption of the grief process. Okay. Now, good news is there are lots of pretty effective treatments for people with complicated grief. I mentioned for acute grief, most people don't need any kind of formal treatment, although support is very helpful to all those. We all grieve more effectively with support. For complicated grief, on the other hand, without treatment, it tends to endure. It tends to either go on indefinitely or only partially remit over time. But there are lots of treatments, and I'm struck in listening to Ted this morning and having read his book and having just recently read one of Jack Jordan's books on attachment-based therapy, that there are more commonalities than differences and in all of these. And some of the common things are developing a relationship with someone, having them tell their story, and dealing with helping them accept the loss and accept life in a new context. So many of these therapies can be very helpful, individual or group, some web-based therapies that have been shown to be effective. The one I know the most about, the one I'm trained in, and the one that I think really has the largest database for efficacy right now is something called complicated grief therapy, developed by Kathy Shear and colleagues. The complicated grief therapy is a manualized 16-session therapy, targets complicated grief symptoms. She considers it a form of CBT. I'm not sure I totally agree with that. It really is an amalgam of cognitive behavioral therapy, prolonged exposure therapy, interpersonal psychotherapy, dynamic therapy, supportive therapy, retelling therapy, attachment-based therapy. But it does have a lot of cognitive behavioral components to it. Uses strategies from all of these, including motivational interviewing as well. The strategies are it tends to this dual process that Ted mentioned. It addresses complicating thoughts, feelings, and behaviors, the shoulda, coulda, woulda, ifs that are hanging up the mourning process are very actively addressed in this therapy. There's a rhythm in each session and over time between confrontation with the loss and providing comfort. And both loss-based interventions as well as restoration and life-based interventions at the same time. The procedures are psychoeducation, helping normalize, helping educate the person about the grief response, developing a relationship. And the first couple of sessions are very much, as Ted described in the work he does, tell me the story. I want to know about you. I want to know about the person who died. I want to know about your resources, other deaths you faced, etc. So the first several sessions are really getting a very detailed history, particularly around relationships and losses. One of the key procedures is involving a significant other. So generally in about the third session, the person is asked to bring someone else in and help not only support them and educate them, but enlist their help in supporting the person who is the identified patient by having them bring them to places, be with them, encourage them, help them get activated, etc. So significant others are a part of the treatment. Grief monitoring. Many people with complicated grief are very much avoidant of their grief and try and ignore it whenever they can, and we ask, no, pay attention to it. When your grief is most intense during the day, what's going on? Do a diary, do a checkpoint. When things are better for you, what helps that? What's going on? And help them begin to pay attention to the way they're feeling, kind of being in the moment, mindfulness, if you will. A key component is the imaginal and situational revisiting. So in about the fourth session, we ask people to tell the story. Close your eyes and tell the story of when specifically you learned about the death. What is the imagery? first-person narratives, active verbs, and throughout this kind of monitoring how the person's feeling. We tape that session. Usually, it's not a prolonged exposure. It's not 30 minutes of this. It's usually about 10 minutes. Tape it. They take the tape home with them. They're asked to listen to it every day and then put it away. And they're asked to reward themselves every day for having listened to it. So you're dealing with the loss and restoration and life without the person. Self-compassion is part of it. Over time, it gets easier to tell the story. And we have them process it. So immediately after telling the story, open your eyes, tell me about it. What did you learn? What did you experience? What was that like? And the story changes over time. And more details are filled in. There's also situational revisiting exercises a little bit later where, what are the places you're now avoiding? The restaurants that you used to go to, movies, you watch TV shows, people, and begin to strongly encourage them to begin to face those things they're avoiding and monitor their responses and do more and more. And sometimes the other person can be very helpful in that. Memories and pictures are part of it, as Ted mentioned. We have them, bring in things you've read, bring in pictures, let's talk about it, bring in videos, things to help, again, deal with the loss of the person who's died. At some point a little later in the therapy, a very intense form of the phase of the treatment, kind of a gestalt empty chair thing where we ask them to have a conversation with the person who's died, put them in an empty chair, talk to them, listen to them, engage with them, what are the things you would have liked to have said, etc. That can be very powerful as well. Throughout and at every session, we also attend to self-care, core values, and meaningful future plans. And people often early on, when you say, I want you to, what are your goals? What would you have wanted for yourself? What would John have wanted for you, etc. People, I can't do that. That's very difficult. But we really push that and have people begin to face. The one person I treated, whose wife had killed herself about a year before we started treatment, felt he couldn't have any goals for himself without her. And then finally, in about the fourth session, very sheepishly said, what he really wants is another relationship. And he was ashamed to bring this up. And by the 12th session, he was in a new relationship, and he never thought that was going to be possible for him. So really pushing meaningful goals. Okay. Now, this therapy works. And this is data from two of the first large studies. The comparative group was interpersonal psychotherapy, so another very robust form of therapy that was developed in part to help people deal with grief. And as you can see, the CGT compared to the interpersonal psychotherapy had substantially higher rates of responders. In the first study, 51% versus 28%. In the second study, even better, 71% versus 32%. Very, very effective in these large comparative psychotherapy studies. There was a hint that medications may be helpful. The studies weren't meant to study medications for complicated grief, but many of the patients had comorbid PTSD or depression, had been on meds, sometimes mistakenly on meds because their doctors didn't know what else to do for them and were mistaking their grief for depression. But in any case, in looking at those who were on meds during the study versus those who weren't, there was a slightly better response for those on meds, but over on the right, what we found was with the complicated grief therapy, not so much with interpersonal therapy, but with the complicated grief therapy, people who were taking meds were actually much more likely to complete the therapy. And the idea was, gee, maybe the meds allow one to withstand the trauma of this very intense exposure-based therapy. And maybe that was a value. But there was at least this hint that meds might have a role, antidepressant medications might have a role. So that brings in the HEAL study, what I'm going to talk about. The HEAL study, Healing Emotions After Loss, was a 4-site large study with several hundred patients, And our main goal in this is to see, do meds have a role? And if so, what is the role in treating people with complicated grief? So the first aim was to determine people getting either citalopram, an antidepressant, or placebo meds at 12 weeks, what was the response of complicated grief? And second goal is for people who got the complicated grief therapy at 20 weeks, which was enough time for the therapy, was there an advantage to being on meds plus this therapy as opposed to either therapy alone or meds alone? So those were the kind of two overriding aims of this study. 4 sites: Columbia, Mass General, University of Pittsburgh, and UCSD. These are my collaborators. This Kathy Shear was the overriding PI, Naomi Simon, the PI at Mass General, Chip Reynolds at Pittsburgh, Barry Lebowitz was an active methodologist and consultant throughout this process. And the design of the study was you could get 4 possibilities. You could get the citalopram alone, you could get placebo alone, or you could get the complicated grief therapy plus citalopram, or the complicated grief therapy plus placebo. So 4 possible cells. All participants received what we call complicated grief informed clinical management. So even if you got placebo with no therapy, you were seeing somebody every other week who was a kind, compassionate person who talked to you about your grief, who asked about it, who encouraged you to be active and engage in activities. So this was nothing like just placebo medication. The AFSP also sponsored our ability to enhance recruitment of people whose bereavement was related to a suicide of a loved one. So our goal was to recruit an additional 70 individuals with suicide bereavement, not so much to test the medications, because there weren't enough to really do that, but to see, is this form of psychotherapy effective for people with bereavement post-suicide? So, main outcome of the study, and this has just been recently published in JAMA Psychiatry, believe it or not, I know you'll have trouble wrapping your head around this, but medications are not the treatment of choice for complicated grief. We were actually a little disappointed to find that result because we were, we're all psychiatrists and we all prescribe a lot. But medications, and this is at 12 weeks, versus placebo, the bar is a little taller with the citalopram, but there was no significant difference between placebo meds or antidepressants for grief. Okay, meds are not the treatment of choice. Second aim was at week 20 in people who got the complicated grief therapy. So the half of the people who were randomized to complicated grief psychotherapy, do meds help? And so we looked at that group on, complicated grief therapy plus meds versus plus placebo. With the idea is that so often we think, well, both are better than just one or the other. Well, in this case, that wasn't the case. Meds were no better than placebo for people getting complicated grief therapy, for grief as the outcome. If you look at depression as your outcome, actually depression scores did get better in people who are on active antidepressant, and that's important. But the grief did not budge. I mean, there's just no difference. Third, and this looks at in the yellow bar, the group getting citalopram alone versus citalopram plus complicated grief therapy. The group that got complicated grief therapy did better than citalopram alone. Now, by the 20th week, getting the citalopram along with this clinical management, seeing someone every other week who was kind, compassionate, encouraged you to get out there, was pretty powerful. 69%, but not nearly as powerful as the therapy. Okay. The other thing I might mention is that when I said before that depression got better with meds versus placebo, it only got better in the subgroup of people who were receiving the complicated grief psychotherapy. So in the 50% of people who did not get randomized to therapy, depression didn't even get better with antidepressants. But if they got both the therapy and the active medication, depression got better, which is kind of interesting. We weren't expecting that, but it kind of makes sense. Okay. And this is if we just look at the 4 cells. Placebo, no psychotherapy; citalopram, no psychotherapy; psychotherapy plus placebo; psychotherapy plus citalopram. Again, the psychotherapy plus placebo was better than placebo. The psychotherapy plus citalopram was better than just citalopram. Okay. And no difference between placebo and citalopram without the psychotherapy. Yes?
What measure of depression did you use?
We used a couple, but the main one was the QIDS, which is the Quick Inventory of Depression, developed by John Rush. It's like a Hamilton, but it's probably become the gold standard, and measures the QIDS, the 16-item QIDS, measures all of the symptoms that are in the DSM definition, and rates them from 0 to 3. So conclusions from the study overall. Our study confirmed the efficacy of CGT. It wasn't our goal, but it did it. Marked reduction of symptoms in people getting the complicated grief therapy. Second, contrary to our hypothesis, antidepressant medications had no main effect on complicated grief, nor did it enhance treatment of complicated grief when grief was of complicated grief therapy when grief was the outcome. The other conclusion we have is this form of therapy is very learnable. I learned it. If I can learn it, anyone can. So psychiatrists even might want to begin to include it as part of their therapeutic armamentarium. It is learnable. There isn't a residency training program in the country that teaches this, but maybe we ought to start thinking about providing this form of therapy or other grief-related therapies for such a common problem that we want to be training more people that can provide it. But it's not only psychiatrists that don't provide it. In most cities, there aren't people who have been certified or trained in complicated grief therapy. And I think it's a useful form of therapy that I would say we need to do better with. But in the absence of the availability or any availability maybe of any of the evidence-based psychotherapies in a city where TED isn't or Jack isn't or no one does CGT, that the complicated grief-informed clinical management can be very, very effective. Over 20 weeks, 65% response rates in people simply getting this grief-enhanced and informed clinical management. Okay. And this is what the clinical management comprises of: psychoeducation, monitoring symptoms, empathic listening, and supporting the person to return to enjoyable activities even in the absence of the deceased. Okay. So now I'm going to move to the topic of my presentation, and that is suicide bereavement. In our study, we had the people that got randomized. We ended up having our 70, but we're only going to talk about those that got randomized here. 58 suicide bereaved who got randomized. We separated out a group, for TED's sake, of people with either accident or homicide bereaved, with the idea that they also would be very different than people bereaving somebody who died of natural causes of deaths. And there were 263 natural bereaved. So we had just almost 400 subjects who got randomized here in the subject. First question is, are the suicide bereaved different? Are they? Any guesses? They are. How so? How do you think they're different?
I think it's kind of shocking for the person.
Okay, so maybe more shock, more trauma related symptoms, sure. Other things that we might have found are
The social stigma.
okay.
This is the amount of,
Yeah.
and the type of support that people get.
There is more stigma, and that may affect the type of support people have, and we'd see that more with the suicide bereaved than the other two groups. Yes. Any other thoughts? Yeah.
It's by volition. It's a choice. that was made versus an accident
Yeah.
or somebody else outside the person.
So the death has volition as a part of it, but how does that affect the bereavement process?
Because who to blame?
Okay, so blame, including blaming the person who died, or blaming oneself for not having stopped it. So you might expect that to be a difference. Anything else? Yeah.
Just related to that is feeling guilty and lots of if onlys. Why didn't I do something?
Right. So you'd expect to see a lot of that. I wish we measured all those things you're mentioning, but yeah, I probably don't need to show the rest of my slides because, yeah,
There's also the risk of suicide.
the risk of suicide may be greater. Okay. Super. Well, wouldn't it be nice to confirm all that? We'll see. All right. So, suicide rates are going up, and for every suicide, there are at least 4 to 8 people who are grieving intensely. And this is some material about suicide bereavement and survivors, and so much of it comes from Jack Jordan, who you're going to hear a little bit later, of some of the differences that we might expect and kind of thematic differences people are dealing with, like the question why, asking why, trying to understand it, trying to figure it out, trying to make sense out of this, what seems like such a senseless, tragic, untimely death. So why questions? Responsibility, assigning responsibility either to oneself in the form of guilt or self-blame, or to others. You know, why didn't someone else take care? Why didn't the psychiatrist do better? Or even blaming the person themselves. How could you do this to me? How could you abandon me? How could you reject me? Shame involved with stigma and leading to social isolation, both because of one's own sense of being stigmatized as well as stigma coming from others. And family relational disturbance, very common for families to get on blaming each other and creating stress and trauma within the family situation. Anger, anger at the person, anger at oneself, anger at others who may have stressed the person, anger at God, anger kind of as an adjective looking for a noun in this case. Other important issues, again, much of it coming from Dr. Jordan's work, kind of the horror and trauma symptoms that you mentioned that are part of suicide loss and part of certainly loss after accident or homicide. The increase in suicidality in the survivor and the risk for complicated grief. And death by suicide has been shown in several studies to be a substantial risk factor for complicated grief, as one might guess. Okay. And this study, again, what we're going to show now is by no means can be generalized to people who have lost someone to suicide. This comes from a specific subpopulation of people not only who have had a loss by suicide, but also have complicated grief, also are seeking treatment in a study where they are willing to be randomized to either medications or therapy or both. So it's a specific subsample of people with complicated grief and who are willing to accept medications and or psychotherapy. Okay. Within that population, the group who were suicide bereaved tended to be younger than the other groups, tended to seek treatment in a more recent, more proximally to the death, but still 4 years later. Now, many of these people had been in treatment, but very often ineffective treatment, and often complained about the people they were in treatment with just not understanding it at all, and their treaters as well as their friends being frustrated with them for not getting over it, not getting on with their lives, etc. And many of them hadn't been in treatment for this time. But after accident or homicide, it was almost 7 years after the death before people came in treatment. And I think that people after an accident or homicide expect themselves to be bereaved for such a long time that they don't consider themselves ill until many years later when they're still suffering as much as they were within a very short time after the person who died. There was no significant difference in gender. Women came into our study much more often than men. As Ted mentioned, women are so frequently the clients. The suicide bereaved were less likely to be bereaving the loss of a parent than the natural deaths, but more likely to be bereaving the loss of a child, as were the accident homicide bereaved. So the traumatic bereaved groups, suicide, accident, homicide, tended to much more often be bereaving the loss of a child than the natural death group. Okay. In terms of severity of complicated grief, no difference. So whether the loss was from suicide, from accident, homicide, or from natural causes, there were no significant difference. The numbers look a little bit larger in terms of those who were severely or markedly ill on a rating scale, higher with the suicide bereaved, but there was actually no statistical difference between groups. And in terms of a mean score in the inventory of complicated grief, which is kind of the scale that most people use to measure complicated grief, they were identical scores, all 43, all very high. The minimal score to get into the study was 30. The minimal score to get in most studies is 25. In our study, the average score was 43 in all three of these cells. Depression, the same in terms of severity of current depression. And this is fairly consistent with the literature that often finds, to our surprise, that people, even after the loss of somebody by suicide, don't necessarily have more depression and not necessarily more PTSD either than individuals after other losses. The WSAS is a scale for social adjustment, and the mean impairment score was greater with the suicide bereaved. So the suicide bereaved in the study, their complicated grief was no more severe, their depression was no more severe, but they did appear to be more impaired on the WSAS. Now, this looks at major depression, PTSD, and active suicidal ideation. The group with suicide bereavement were more likely to have a lifetime history of major depression, 97%, almost everyone, almost invariable. This is much higher than you would see in most studies, but again, this is a treatment study of people with complicated grief willing to accept medication, so it may be a unique sample. But the vast majority of all of our patients had a history of major depression before the death, especially the suicide bereaved. Current depression was high in all of our groups, but no higher in the suicide bereaved than in the other groups. On the other hand, PTSD was high both lifetime before the death as well as currently when people entered our study. And in terms of active suicidal ideation, high in all the groups, particularly in the suicidal bereavement group, but current suicidal ideation, again, this is several years after the death, 43% of those who came into our study because of losing a loved one to suicide, 43% of them had active suicidal ideation, more than just the wish to be dead, but actively thinking about killing themselves. Extraordinarily high for a disorder that we need to be paying a lot of attention to. This looks at a scale, the typical belief scale, which looks at issues, themes, and beliefs that people had. The suicide bereaved were different from either of the other groups, much more likely to have lost the ability to care about others. They were more isolated. They didn't feel they could provide care to others or be available to others, including family members and children. And much more likely, as we would have guessed, to feel that they should have done something to prevent the suicide. So more self-blame and more guilt, yeah.
On the previous slide, did you check like ACE scores or anything like that with early childhood trauma?
We didn't have that in this, no. I wish we did. Whether we had ACE scores, like a measure of earlyhood trauma and attachment. And we didn't have that. It would have been interesting to have. The suicide bereaved were different than the accident homicide bereaved in a couple ways. One was they were more likely to feel that others were tired of their endless grief. They felt like they were much more likely to be a burden on other people, and probably stigma relates to that. And were much more likely to say it's difficult to spend time with others, and I can't share my grief with others. The accident suicide bereaved were much more likely to say the world is filled with unpredictable dangers and bad things are uncontrollable. So there's a sense that suicide bereavement, the suicide is controllable, and that's related to the blame and anger, whereas accident homicide less so. And the suicide bereavement is different than the natural cause bereaved, but not necessarily the accident, in that saying the loved one didn't have to die this way, the death should not have happened, it isn't fair that the person who died, and less likely to say that they just don't understand why the grief isn't getting better. So again, there's this sense of I deserve it and blame, and this could have been prevented, that prevail in these belief models. Okay, now the treatment. How did they do compared to the other groups in terms of treatment? If we look at medication completion rates, the suicide, and this is the 4 groups, so meds, no therapy, placebo, no therapy, meds plus therapy, placebo plus therapy, and we look at just completing 20 weeks of medications, what we find is the suicide bereaved who didn't get therapy dropped out at very, very high rates. So the medication completion rates for those not assigned to complicated grief therapy were lower for the suicide bereaved than for those dying from accident, suicide, accident, homicide, or natural causes. And we found that the medication completion rates for the suicide bereaved not assigned to CGT were lower than those who were assigned to CGT. So if you don't get therapy and you're suicide bereaved, you're not going to take meds. You don't want meds in the first place usually, but if you agree to take them, you're not likely to take them for very long. Unless you get therapy, but even then you're less likely to take them than the other groups. So for that group in particular, I think a formal psychotherapy is critically important. Medication completion, dropouts tended to be early, often within the first week before the first assessment. 31% of the dropouts from meds occurred before the first formal assessment. And due to the low completion rates for meds, we can't really reliably assess treatment response in the groups in relationship to meds. The acceptability of CGT, on the other hand, the complicated grief therapy, was quite high in all of our groups, including the suicide bereaved. So about 75% of all people finished the complicated grief therapy as opposed to the meds, where many people dropped out. For the suicide bereaved, in terms of dropout rates, the dropout rates tended to be fairly equal between those who were assigned to meds versus placebo. Response, okay. So in terms of our response, which is having a clinical global improvement score of 1 or 2, meaning very much improved or much improved, in the suicide bereaved groups, you see that these columns are shorter than in the others. So the overall response to suicide bereaved was not as good as it was in the accident homicide bereaved or the natural death bereaved. But it was good. I mean, 2/3 of people in the suicide bereaved group had a good response. But the complicated grief therapy was so robust that it was even better for the others. But still, 2/3 response is I think, quite impressive. If we looked at active suicidal ideation changes with the complicated grief therapy, the suicidal bereaved, 43% had suicidal ideation at baseline before the study, 0% after the grief therapy. and also substantial drop-offs in the other groups. So the suicidal bereaved had a pretty good response rate, not as good as the others, very good response in terms of diminishing suicidal ideation. And some of the other outcomes, here we look at changes in the ICG, which is the measure of complicated grief intensity, about the same. There were substantial changes, decreases in complicated grief intensity in all groups. Impairment, measured by the WSAS, about the same. So all groups had less impairment after complicated grief therapy. All groups had much less avoidance of activities, behaviors, thoughts that reminded them of the person who died. And all groups had a lowering in their TBQ scores, which means their maladaptive belief scores, all lowered, about the same in all groups. So I think what we're showing is the suicide bereaved group number 1, meds alone is not the treatment, even less so than the others. Number 2, the adherence to the psychotherapy is quite good, similar to the others. That the overall response wasn't quite as good, but many of the other measures, such as decrease in suicidality, increase in functioning, decreases in grief intensity, decreases in avoidance, and decreases in maladaptive beliefs, all improved equally well with the suicide bereaved group. So in summary, suicide survivors face acute grief reactions and challenges that are similar to those encountered by anyone dealing with the death of a loved one or a relative. But in addition, they also have some unique challenges. Additional vulnerability to lifelong struggles with mental health issues, more lifetime depression, more lifetime PTSD, more previous suicidal ideation. A greater likelihood of developing PTSD and suicidal ideation in the context of their loss, and a host of potentially maladaptive thoughts, beliefs, and behaviors, including the thought that this could or should have been prevented, i.e., I could or should have done more to prevent it. More distance from others, more stigma, and greater functional impairment. So they have all of the challenges of anyone else who's bereaved and has complicated grief, and more. So the clinician should be especially vigilant for these features. And my guess is that the reason the overall response rates may have been lower in that group may have been related to some of these issues needing to be attended to, and perhaps moving a little bit more slowly with the exposure part of the treatment and attending to some of these other issues in the development of the relationship phase of the treatment. But I think that's another study that needs to be done. CGT is an effective form of treatment for complicated grief. We now have preliminary evidence, at least, that this complicated grief therapy is feasible to administer, well tolerated, and effective for those with complicated grief following a loved one's death. So the treatment of survivors with complicated grief is important in order to avert future psychiatric and family dysfunction and perhaps even future suicides. Effective recognition and treatment among survivors should be a high priority for intervention efforts following suicide loss. We need more people able to provide treatment. And finally, more research is needed. I think that the study poses many questions as well as some preliminary answers. And for whom is this therapy most effective? For which subgroup may some combination of meds plus the therapy be more effective? And how can the therapy be adapted so that the response rates are every bit as robust for suicide bereaved as for other groups? Are all questions for future research. And I just want to end with another, Ted gave one very valuable website. Another one is the www.complicatedgrief.org, which is Kathy Shear's website at Columbia, which has lots of information on complicated grief, some on suicide bereavement, and also the availability of trainings for the therapy. the manual is available. Sometimes there's a free manual that's sometimes available that's an abbreviated form. I'm not sure where that stands right now. But it's a valuable website and one that I go to for information from time to time. So time for questions, Ted, or how are we doing on time? Okay, great.